Biology doesn't care about your politics, and malpractice juries definitely don't care about your equity initiatives. $50 million settlement paid because surgeon refused standard surgical equipment. 18 months of medical review board warnings completely ignored. VIP patient left with permanent disability. Family retained top malpractice firm. Me, 44, chief of surgery at prestigious academic medical center in Boston. Spent 20 years working my way up from resident to department head. About to watch ideology destroy hospital's reputation and my career. Because someone decided surgical instruments had a gender. Here's how a feminist surgical protocol bypassed every safety committee and turned our hospital into a $50 million case study in medical negligence. Let me establish context. This is important for understanding scale. Boston Medical Institute, one of the city's premier facilities. 800 beds, level 1 trauma center, top-ranked in cardiology and oncology. Annual revenue $600 million. NIH research grants, teaching hospital. I'm chief of surgery, oversee all surgical departments and 85 surgeons. Making $425,000 annually. Been in this role for 6 years. Responsible for outcomes, safety protocols, quality metrics, everything. Our surgical departments have strong track record. Low infection rates, good patient outcomes, national recognition. I got here by following evidence-based medicine and strict protocols. Medicine is conservative for a reason. Change requires data and validation. Can't experiment on patients with unproven techniques. Every protocol we use has been tested, peer-reviewed, validated. That's how you maintain safety and avoid malpractice. January 2023, hospital administration announces major initiative. CEO William and board want to rebrand our women's health services. They're concerned about equity scores and public perception. Want to be recognized as leader in women-centered healthcare. Hire a consulting firm to assess our brand and recommend changes. Consultants say we need visible feminist leadership in surgery. Recommend hiring prominent female surgeon with strong public profile, someone who can generate positive PR and improve our equity metrics. Board approves search for Director of Women's Health Surgery. New position, $380,000 salary, significant autonomy over protocols. I'm on hiring committee along with hospital administrators. We interview several qualified candidates, all excellent surgeons. Then we meet Dr. Melissa, age 39, tremendous credentials. Harvard Medical School, fellowship at Johns Hopkins, board certified. But what stands out is her social media following. 500,000 followers across platforms. Known as Feminist Surgeon. Writes articles about gender bias in medicine. Does speaking tours. Administration is immediately interested. This is exactly the profile they want. I review her surgical outcomes. They're good, nothing concerning. Standard techniques, appropriate patient selection, normal complication rates. During interview, she talks about her vision for women's health. We need to reimagine surgical care through feminist lens. Current protocols were designed by men for male bodies. Women deserve surgical approaches that center their specific needs. Sounds reasonable on surface. Women do have different anatomy. But then she gets more specific about what she means. Many standard surgical instruments were designed without considering female anatomy. Clinical trials that validated current techniques had male-dominated patient populations. We should question whether these tools and protocols are optimal for women. I'm cautious. Are you suggesting we modify evidence-based protocols? I'm suggesting we evaluate whether those protocols serve all patients equally. Red flag for me, but administration loves her. After interview, William is enthusiastic. She's perfect for our brand. She'll generate tremendous positive attention for the hospital. I voice concern. Her ideas about modifying protocols concern me. We need to ensure any changes are evidence-based and properly validated. COO Janet dismisses this. You're being too conservative. We hired her for fresh perspective. Let's give her room to innovate. Board votes to hire Dr. Melissa. She starts in March 2023. First month, she's doing media appearances. Hospital loves the attention. Articles in Boston Globe, features in healthcare publications. Her social media following grows. Hospital's brand metrics improve. Administration is thrilled. Exactly what they wanted. Then in April, she proposes Feminist surgical protocol for review. Submits detailed document to Medical Standards Committee. I'm chair of this committee. We review all protocol changes. Read through her proposal. Alarm bells going off immediately. She wants to replace several standard surgical instruments. Claims they were designed for male anatomy and are suboptimal for women. Proposes using boutique medical devices from small manufacturers. These devices aren't widely adopted, limited clinical data. She cites studies showing standard instruments were tested primarily on men. This is partially true. Historical clinical trials had gender imbalance. But these instruments have been used successfully on millions of women. Decades of real-world data showing safety and effectiveness. Her proposal also modifies monitoring protocols during surgery. Wants to eliminate certain standard checks because they're patriarchal. Argues that constant monitoring implies distrust of surgical judgment. This is concerning. Monitoring is essential for patient safety. Call emergency committee meeting to review proposal. Present my concerns. These changes lack peer-reviewed evidence. The devices she wants to use don't have extensive safety data. Modifying monitoring protocols increases risk without clear benefit. Committee agrees. We vote to reject the protocol. Recommend she pilot any changes in controlled research setting first. Need data showing improved outcomes before implementation. Dr. Melissa is furious. Escalates directly to administration. Meets with William and Janet. Frames committee decision as resistance. This is exactly the gatekeeping that prevents innovation in women's health. Male-dominated committee rejecting feminist approach to surgery. William calls me. We need to reconsider this decision. The protocol aligns with our equity initiatives. It doesn't align with evidence-based medicine. We can't implement unvalidated protocols just for branding. Dr. Melissa has excellent credentials and surgical judgment. Her credentials don't override need for peer review and validation. Janet joins call. We're going to approve pilot program. Dr. Melissa can implement protocol in her surgical cases. That bypasses Medical Standards Committee entirely. We're making executive decision. This is about hospital strategy. I'm stunned. They're overriding safety review for PR purposes. Document my objections in writing. Send to William and board. Implementing unvalidated surgical protocols without committee approval creates significant liability and patient safety risks. I strongly advise against this decision. Response from legal counsel. Your concerns are noted. Hospital leadership has approved limited pilot implementation. Please support Dr. Melissa's initiative as Chief of Surgery. May 2023, Feminist surgical protocol goes into effect. Dr. Melissa begins using alternative instruments and modified monitoring. I'm required to sign off on surgical schedules, including her cases. Document every instance. Keep detailed records of my objections. First month, outcomes seem normal, no obvious problems. But I'm watching metrics closely, tracking her cases specifically. June 2023, start noticing patterns in data. Dr. Melissa's average surgical time is 15% longer than standard. Her infection rates are slightly elevated, not dramatically, but measurable. Readmission rates are higher, patients coming back with complications. Bring this to medical quality review meeting. Dr. Melissa's outcomes are trending negative compared to baseline. We should pause protocol implementation and review the data. Dr. Melissa attends meeting, defends her approach. Any new protocol has adjustment period. These variations are within normal range. not statistically significant. She's technically correct. Differences aren't huge yet. But trajectory is wrong direction. This should concern everyone. Chief Nursing Officer Karen supports my position. Or nurses have reported concerns about the new instruments. They're less familiar with them. Creates workflow inefficiencies. Several nurses have mentioned they prefer standard equipment. Dr. Melissa dismisses this. Nurses are resistant to change. They're comfortable with old ways. That doesn't make old ways better. Anesthesiologist weighs in. I've noticed monitoring gaps. The modified protocol reduces my visibility into patient status. Makes my job harder to ensure patient safety during surgery. Dr. Melissa responds that monitoring was excessive. It reflected distrust of surgical competence. We're creating more collaborative surgical environment. I'm listening to this thinking it's insane. Monitoring isn't about trust, it's about safety redundancy. Multiple checks catch problems before they become disasters. Meeting ends without resolution. Administration sides with Dr. Melissa. Let's give the protocol more time to demonstrate results. July 2023. Complications continue increasing. Another medical quality review, more concerning data. Dr. Melissa's complication rate is now 20% above department average. 3 patients required additional corrective procedures. 1 developed serious infection requiring extended hospitalization. I present this data. We need to suspend protocol immediately. These outcomes are significantly worse than standard care. Dr. Melissa has explanation for every case. That patient had comorbidities that complicated recovery. That infection was unrelated to surgical technique. These are all within accepted ranges for complex procedures. She's not technically wrong. Complications happen in surgery. But pattern is clear to anyone looking objectively. Her outcomes are worse than surgeons using standard protocols. Vote to recommend suspension of Feminist protocol. Committee votes 8-2 in favor of suspension. Send recommendation to William with detailed statistical analysis. William schedules meeting with me, Dr. Melissa, and legal counsel. We've reviewed your recommendation to suspend the protocol. We're declining to implement suspension at this time. The data doesn't conclusively prove the protocol is causing issues. I'm prepared for this. Brought statistical analysis. The probability that these outcomes are random chance is less than 5%. That's the standard threshold for statistical significance. We have enough data to conclude protocol is causing harm. Legal counsel intervenes, but we don't have certainty. Dr. Melissa's explanations for individual cases are reasonable. Suspending protocol could expose hospital to discrimination claims. That's the real concern. They're more afraid of discrimination lawsuit than they are of malpractice lawsuit from bad outcomes. We're risking patient safety to avoid PR problems. That's not a decision I can support as chief of surgery. William is firm. The protocol will continue. We're committed to Dr. Melissa's innovative approach. Your concerns are noted, but we're proceeding. August 2023, I escalate to hospital board. Request presentation at board meeting to discuss safety concerns. Prepare comprehensive analysis of outcomes data. Show comparison between Dr. Melissa's cases and department averages. Clear statistical evidence of worse outcomes under new protocol. Board members are concerned, but conflicted. One board member, this data is troubling. But how do we balance safety concerns with equity initiatives? Another, are we sure this isn't just resistance to change? Dr. Melissa has impressive credentials. Maybe we need more time. I'm direct. Medicine doesn't work on equity initiatives. It works on outcomes, and these outcomes are worse. Every month we continue this protocol. We're exposing patients to unnecessary risk. Dr. Melissa presents counterargument. Traditional metrics weren't designed to measure patient-centered outcomes. My patients report higher satisfaction with their care experience. We need to value their voices, not just statistics. Board is swayed by this. They like patient satisfaction argument. Vote to continue protocol with enhanced monitoring. Whatever that means, it's meaningless compromise. I leave meeting knowing this will end badly. September 2023, the inevitable happens. High-profile patient scheduled for complex gynecological surgery. Woman named Elizabeth, age 52, wife of prominent attorney. Wealthy, well-connected family, significant medical complexity. She specifically requests Dr. Melissa after seeing media coverage. Wants feminist approach to her surgery. Pre-surgical review. Case is challenging but manageable. Requires careful technique and standard monitoring protocols. I review surgical plan. See Dr. Melissa is using feminist protocol. Pull her aside. This case is too complex for experimental protocol. Use standard instruments and full monitoring for this one. She's offended. Are you saying my protocol isn't safe? I'm saying this patient has multiple risk factors. We should use most proven approach available. My approach is proven. I've done dozens of cases. We're at impasse. She refuses to modify her plan. I document this conversation. Send email to administration. I've advised against using unvalidated protocol on high-risk patient. Dr. Melissa has declined to modify approach. I'm documenting this recommendation for liability purposes. Surgery proceeds on September 28, 2023. I'm not in but I'm monitoring from administrative office. Procedure is taking longer than expected. For hours, should be 2.5. Get call from anesthesiologist, we're having issues. Dr. Melissa's instruments aren't working as expected. She's having difficulty with standard technique steps. My heart sinks. Does she need assistance? She's managing, but it's taking much longer than normal. And we've had some monitoring gaps due to modified protocol. Surgery completes after 5.5 hours, extremely long. Patient goes to recovery, initially seems stable. But over next 48 hours, complications develop. Internal bleeding that wasn't detected immediately. Requires emergency return to or for corrective surgery. This time with different surgeon using standard protocol. Patient develops serious infection, spends 2 weeks in ICU. Ultimately survives, but with permanent complications. Long-term disability requires ongoing medical care. Family is understandably upset. Retains major malpractice firm. October 2023, family's attorneys request all medical records and all communications about feminist surgical protocol. Discovery process begins. They subpoena everything. My emails warning about protocol risks. Committee votes to suspend protocol. Board meeting minutes where I presented safety data. All of it goes to plaintiff's attorneys. November 2023, hospital legal team reviews case. They know we're in serious trouble. Liability is clear. We ignored documented safety concerns for 18 months. Implemented unvalidated protocol over medical committee objections. Patients suffered harm that likely wouldn't have occurred with standard care. Recommendation: settle quickly before trial. Plaintiff's attorneys demand $75 million. Hospital offers $30 million. Negotiations begin. December 2023, settlement reached at $50 million. Largest malpractice settlement in hospital history. Insurance covers $30 million. Hospital pays $20 million from reserves. This is catastrophic financial hit for the institution. Board convenes emergency meeting to address crisis. William and Janet are asked to resign. They do. Dr. Melissa is not fired. She resigns to pursue other opportunities. Takes position at medical think tank, $500,000 annually. Continues speaking career, now framing herself as whistleblower. I tried to innovate women's health care, but institutional resistance was too strong. Completely rewrites history. She's the victim in her version. I'm called into board meeting in January 2024. We need someone to take responsibility for oversight failures. You were chief of surgery. This happened under your watch. I'm prepared with documentation. I objected to this protocol from the beginning. I documented safety concerns escalated to every level. I was overruled by administration for PR purposes. Board chair acknowledges this. Your documentation is clear, but we still need organizational changes. We're restructuring surgical leadership. Translation: I'm being demoted for being right. Removed as chief of surgery, moved to associate chief position. Salary reduced from $425,000 to $285,000. New chief of surgery is brought in from outside. His first directive: immediate review of all surgical protocols. Feminist protocol is suspended on his first day. Return to evidence-based standard protocols across all departments. March 2024, insurance company audit results released. Hospitals' malpractice premiums increase 300%. Additional $15 million annual expense due to increased risk profile. This compounds financial damage from settlement. Hospital forced to cut budgets across all departments. Surgical department loses 15% of budget, have to lay off staff. 3 excellent nurses, 2 physician assistants gone. Programs we'd built over years eliminated for cost savings. All because administration prioritized PR over patient safety. April 2024, U.S. News rankings released. Hospital drops from number 8 to number 24 in surgical specialties. Reputation damage is massive, referring physicians notice. Patient volumes start declining, revenue drops. Board brings in turnaround consultants to stabilize finances. May 2024, regulatory agencies complete investigations. Massachusetts Board of Medicine issues sanctions. Requires hospital to implement enhanced protocol review process. All new surgical protocols must undergo 18-month validation. Independent medical board must approve any deviations from standards. This is necessary, but it's embarrassing. We're being supervised because we couldn't supervise ourselves. June 2024, Dr. Melissa publishes article in Medical Journal. The resistance to feminist innovation in academic medicine. About her experience at our hospital. Frames entire situation as institutional sexism. I attempted to implement patient-centered women's health protocols, but patriarchal medical establishment rejected innovation. No mention of complications, bad outcomes, or $50 million settlement. Just narrative about how she was suppressed for being progressive. Article gets significant attention in certain circles. She's invited to speak at conferences, interviewed on podcasts, building entire career on being martyr to medical conservatism. Meanwhile, I'm at hospital dealing with actual consequences. Reduced budget, reduced authority, reduced salary. Watching programs I built get dismantled for cost savings. All because I try to prevent exactly what happened. August 2024, run into former colleague at medical conference. She left hospital after settlement, took position elsewhere. We talk about what happened. She's sympathetic. You were right from the beginning. Everyone knows that. Doesn't matter now. I paid price for being right. Administration should have paid price. They made decisions. They resigned with severance packages. You got demoted. That's how institutions work. Protect executives, sacrifice middle management. She's right. William and Janet got golden parachutes. I got pay cut and demotion despite being vindicated. October 2024, patient Elizabeth gives interview. Talks about her experience and ongoing health problems. I trusted that hospital. I trusted Dr. Melissa's expertise. I wanted innovative women-centered care. Instead, I got experimental protocol that caused permanent harm. She's advocating now for stronger medical protocol oversight. Wants regulations requiring patient consent for non-standard techniques. Her advocacy is good, but it came at terrible personal cost. Now it's February 2025, 2 years after this started. I'm still Associate Chief of Surgery. making $285,000. Hospital is slowly recovering financially and reputationally. But scars remain. We're years away from full recovery. Dr. Melissa is thriving, speaking fees and consulting income. She's positioned herself as expert on gender equity in medicine. Makes probably $500,000 annually, more than she made here. And she did it by failing spectacularly and reframing failure as martyrdom. Elizabeth is permanently disabled. Her settlement money doesn't restore her health. Can't undo the complications she lives with daily. Hospital paid $50 million plus ongoing increased insurance costs. Lost reputation, lost rankings, lost programs. Dozens of employees laid off, careers disrupted. All because administration prioritized equity metrics over patient outcomes. That's the complete story of feminist surgical protocol. How ideology bypassed every safety mechanism. How PR concerns overrode medical judgment. How fear of discrimination claims led to actual patient harm. And how the person who caused it all walked away richer, while everyone else paid the price. I learned several lessons from this disaster. First, medicine cannot bend to ideology without consequences. Biology doesn't care about your political framework. Anatomy works according to principles, not preferences. Second, documentation matters. Save my career. Without those emails and meeting notes, I'd have been scapegoated completely. Third, institutional courage is rare. Most leaders will choose PR safety over actual safety. Fourth, bad outcomes follow bad processes inevitably. We knew protocol was problematic, data showed it clearly. But we kept going until disaster forced stop. Fifth, some people fail upward by controlling narrative. Dr. Melissa turned catastrophic failure into lucrative career by reframing medical negligence as progressive martyrdom. Most important lesson, patient safety must be absolute priority. Not equity scores, not branding, not PR. Just outcomes, data, evidence. Everything else is secondary. 3 years later, I'm 46, still rebuilding. Associate chief position has become permanent. Making $285,000. Not bad, but less than I earned before. New chief of surgery is competent, runs tight ship. We've returned to strict, evidence-based protocols. No more experimental approaches without proper validation. Medical Standards Committee has real authority again. Any protocol change requires peer review and data. We've rebuilt some of what was lost. Hiring back some staff, restarting some programs. But we're still recovering from reputation damage. Rankings have improved, back to number 15 from number 24. Still not where we were before, may never get back there. Dr. Melissa continues her speaking career. Just published book, The Medical Establishment's War on Women. It's selling well in certain markets. Reviews are mixed, some praise, some criticism. Medical community is skeptical, they know what happened. But general public doesn't have access to full story. They just see confident woman with credentials. Talking about institutional resistance to innovation. Sounds compelling if you don't know the details. Elizabeth's family settled with hospital, but they've been vocal advocates since then, pushing for stronger informed consent requirements. Patients must be told when protocols are experimental, must be given choice between standard and alternative approaches. Massachusetts has passed legislation on this. Elizabeth's law requires explicit consent for non-standard protocols. Good outcome from tragedy, at least something positive. I occasionally get calls from other hospitals, asking about our experience with protocol oversight. How did this happen at your institution? What warning signs did you miss? We didn't miss them, we documented them all. Administration ignored them for PR purposes. That's what you have to prevent: executive override of safety committees. Some listen, implement stronger safeguards. Others think they're different, won't happen to them. Same thing we thought before we hired Dr. Melissa. That's the pattern I see repeated. Institutions think they're immune until they're not. Think their leaders won't make same mistakes. But fear of bad press is powerful motivator. Stronger than evidence, stronger than data, stronger than medical judgment sometimes. That's why I learned at 44, watching this unfold, that science and medicine aren't immune to ideology, that institutions will sacrifice safety for perception, that documentation is your only protection, and that some people profit from disasters they create by controlling the narrative afterward. Dr. Melissa making $500,000 proves that. While Elizabeth lives with permanent disability. While I make $140,000 less than before. While hospital struggles to recover reputation. She's thriving, reframed as visionary. That's perhaps the most frustrating part. Not just that it happened, but that the person most responsible suffered least from consequences and benefited most from the failure. That's the final lesson from Boston Medical Institute, where Feminist surgical protocol cost $50 million, multiple careers, one patient's health. Because we couldn't say no to ideology, couldn't defend evidence-based medicine, couldn't prioritize outcomes over optics, until lawsuit forced us to admit that biology doesn't care about your politics, that patient safety can't be compromised for branding, that medicine works on data, not good intentions, and that $50 million settlements